I wanted to start off by thanking the Office of Research Trainees. Amanda's here from the Office of Research Trainees for buying us pizza and getting the drinks. Thank you so much. And yeah, thanks everyone for coming. And most of all, thanks to Dr. Mahadeo Sukhai for being here today to tell us about his new research institute that he's starting off. We're going to get started in just a minute. I think many of us probably know Mahadeo already, but I'll give a few words just to give you, for those who don't know him, a few words about what he's been up to, just so you have a sense of his breadth and depth of experience. So Mahadeo is the world's first congenitally blind geneticist. He is Vice President of Research in International Affairs and the Chief Accessibility Officer for the Canadian National Institute for the Blind, which is known as CNIB. And he has previously served as a researcher at UHN. Mahadeo is also a leading expert on accessibility of graduate and postdoctoral research training in science, technology, engineering, mathematics, and healthcare disciplines. He holds faculty appointments at Queen's, OCAD, and Ontario Tech universities. He is also the chair of the Employment Technical Committee for Accessibility Standards Canada, as well as the external co-chair of the Canadian Institutes of Health Research Expert Advisory Committee on Accessibility and Systemic Ableism. And in his role at CNIB, Dr. Sukhai leads a research program focused on the social determinants of health and inclusion for people living with sight loss in Canada. As Chief Accessibility Officer, Mahadeo also leads organizational culture change initiatives on accessibility and inclusion for CNIB. So with that, I'll turn it over to Mahadeo, and we'll have, we're gonna try, I think you said you had about 50 minutes of slides of presentation, so we'll have time for questions. We have the room till 1:30. I know some people may need to leave at 1, but anyone who needs to leave at 1, we'll prioritize your questions ahead of time. Okay, over to you.
Thank you very much, Tilak. I'm just putting a timer on for myself so that I know if I get to the 45-minute mark, I need to hurry up and try to talk faster. So it's actually a real pleasure to be here. The last time I gave a seminar on UHN soil was July of 2017, when I was actually preparing to leave UHN and take a 3-month sabbatical before I started my new job as then head of research at CNIB. And so what I'm actually going to do in this instance is get to the point by going through a little bit of history of CNIB research and what we do and why we do what we do, and the signature project that will really consume us for the next few decades, which will lead to what Tilak just mentioned, which is the birth of a new research institute. So the screen actually has a stylized cartoon owl on it. It's intended to look more like Hedwig from Harry Potter, but it's a graphic design cartoon owl, so it doesn't quite look like Hedwig. It kind of looks a little bit scary. The owl has the colors of CNIB, Vision Loss Rehabilitation Canada, and Deafblind Community Services. So yellow and blue and green in its plumage. So it's a bit more of a tropical owl, I suppose. And on the logo next to the owl are the words IDEA, Inclusion, Diversity, Equity, and Accessibility, which is the name of my team, a tagline, Knowledge and Empowerment, and the actual CNIB logo itself, which is a paint swatch with the letters CNIB inside it. The title of the presentation isn't Mahadeo's New Research Institute. The title of the presentation is Toward Inclusive Vision Sciences Research in Canada, a Look Back and a Look Forward. So Vision Sciences research as a construct has a particular history and a particular genesis and a particular arc of what it is and who does it and why people do it. One of the very first collaborator meetings that I took when I became head of research at CNIB was with someone in the vision sciences research space who didn't do what traditional vision sciences was made out to be. And his conversation with me was, CNIB has ignored what vision sciences should be for the past 10 years. Why should I talk to you today? And my answer to that question was, hello, pleased to meet you. It's because I wasn't here for the last 10 years and therefore I have no truck with what came before. So let's talk about that evolution a little bit, and let's also figure, oh, there we go. So in talking about the evolution, let's turn a typical scientific presentation on its head. The acknowledgements are always at the end, which is a particularly self-serving thing for a presenter to do, because at the end, everyone's rushing. They're all talking fast. They're trying to get through the presentation. And so the acknowledgement slide is flashed up for all of 3 seconds, just so that the presenter could say, I thank all these people. Any questions? So I'm going to start by thanking all these people, because they're the ones who've helped make this thing go. There are 21 names on the slide. And I'm actually not going to read them all out, but I will say that 19 of these names comprise the current staff and research complement of a research consultant complement of my team at CNIB. It is a big team now. I will tell you a little bit more about this group in total in a little bit, but I do want to acknowledge every single one of them because they contribute to the engine that CNIB research has become over the past 6 years. The 2 names that are on the bottom, Maria Ash and John Rafferty, are the people who actually recruited me into this job 7 years ago now, and the people who gave me the freedom to turn CNIB research into what it is today. And so they deserve my acknowledgement on these kinds of slides and these kinds of presentations. I am also going to, as one must, acknowledge the funders. Our primary funder is the Advancing Accessibility Standards Research Program for Accessibility Standards Canada, who happens to be the funder of several other people in the room. We all get along though. And we've also been funded by Economic and Social Development Canada, the Office of the Privacy Commissioner of the Government of Canada, and Global Affairs Canada. So let's talk about where we came from and how research at CNIB has been transformed over the past 6.5 years. Vision sciences research, I'm going to start by telling you, really needs to be a construct of multiple intersecting subdisciplines within the space. Rehabilitation sciences, public health epidemiology, psychosocial and behavioral sciences, social determinants of health, quality of life, technology, and biomedical research. The challenge tends to be, and I don't actually have a slide that shows this, the challenge tends to be that the history of vision sciences research actually is very specifically biomedical research. It is the acknowledged definition of bench to bedside translational research. We care about drugs, we care about gene therapy, we care about clinical trials, we care about genetics of inherited eye conditions. Those are all important things. I'm a geneticist by training, and so I am never going to say that genetics is not an important thing, but they're not the only things. The things that are missing from the conversation about vision science is everything else, right? Because once we get to a point where there's been a formal diagnosis and we get to a point where there's been an evaluation with respect to treatment and with respect to potential for condition management, you have to get into a conversation about rehabilitation. You have to get into conversations around population data science. You have to get into a conversation about the psychosocial and the behavioral aspects. You have to get into a conversation about social determinants of health and quality of life. You have to get into a conversation about technology within this context. You have to have those conversations. If you don't have them, then what you have is vision loss as a health condition. I was born blind. I actually have more eyesight today than I did when I was born. But I was born blind. It went red for some bizarre reason. I clicked something.
I think there's a lock.
Oh, how rude. So I was born blind, and aside from removing my lenses, I was born with congenital cataracts. I was one of a very small number of people on an annual basis who is born with congenital cataracts. So once my lenses were removed, there wasn't a medical intervention that actually could be done outside of that, given where I was and when I was born. So with that in mind, frankly, the rest of the story actually mattered to me, right? Now, if I were 65 years old and I had developed cataracts and I needed cataract surgery and lens implants and I needed to be able to drive a car because that was my definition of living life at the age of 65, then yeah, absolutely, that eye condition is probably a health condition for you. It's not a lived experience. It's not something you want to consider as a lived experience. It's an inconvenience. It's something that the doc needs to deal with, and then you move on with life. And that's where the conversation around the biomedical comes in. That's also where the conversation around the psychosocial comes in. So irrespective of who you are and where you sit within the spectrum of vision loss, it's not just about the biomedical. And so I'm going to throw that gauntlet down and have folks ruminate on that. Some of you may agree, some of you may disagree, right? And I have to point at the thing.
I'll go to the next slide.
You'll go to the next slide for me, Emmanuel? Excellent. We'll do it that way. So next slide, Tillich. All right. So no, that's right. That's the right slide. So if we acknowledge what the broad sweep of vision sciences is supposed to be versus what I'm going to call the canonical conception of what vision sciences is, and it's canonical in the public view, it's canonical in the health research funding view, right? I could name organizations, but I won't. Yeah, Stuart's laughing. It's canonical within the view of the people who do the science, but it needs to change. At CNIB, it needed to change because CNIB strategy evolved over the last 10 years or so. CNIB strategic plan in 2014 to 2018 was called the Path to Change, and it was about convincing the provincial governments that vision loss rehabilitation therapy needed to be part of the universal healthcare package. The typical answer that we got when CNIB started to do this, I was on the board at the time, not staff, but the typical answer that we got when we started to do this was, you mean we don't already pay for eye care? And we had to say, well, no, actually, you don't already pay for eye care. And then people said, well, that's stupid. Maybe we should be paying for eye care. And so convincing people once the data were there was actually relatively straightforward. So the kind of research that CNIB needed to do needed to be health services outcomes research. It needed to be cost of care, health economics research. It needed to be epidemiology, right? But then when we launched Bold Dreams, Bright Futures, which was the strat plan immediately following Path to Change 2018 to 2023, we needed social determinants of health data. And we didn't have it, right? So CNIB pre-2017 October focused very strongly on health services outcomes and epidemiology and the biomedical, the drugs, the gene therapies, the clinical trials, right? So therapeutic advocacy, CNIB did a lot of, and health economics arguments, CNIB did a lot of, but there wasn't room within that space for the conversations around social determinants of health. And so the conversation needed to change. And October of 2017, when I joined CNIB, we started to shift the conversation into the conversation around social determinants of health and quality of life. Going forward, today, the new strategic plan is called the Way Forward. And in order to service this plan and the future of the organization, we actually need a longitudinal study, which is what I'm going to tell you about, which will lead into the conversation about the new Research Institute. Next slide. So as I said, pre-2017, CNIB research was very epidemiology and biomedical focused. Next slide. Next slide. There we go. So what did I have to start with in 2017, October? Nothing. No staff, no consultants, no projects, no funding, no partnerships, no collaborative relationships, no networks, no trainees. Okay, next slide. Today, not counting me, 10 staff, 9 research consultants, more than 29 projects active, And that's including the stuff that students are doing, 7.75 million over 3.5 years worth of funding. That 3.5 years is interesting because that's actually when the pandemic started. It should be 4 years now. I should have edited that. But we actually started winning money when the pandemic hit. We have more than 20 collaborative relationships, including with some people in this room. Tillich and Allison, I'm nodding at you. And we've got more than 10, actually probably closer to also 20 partnerships with universities and colleges. We've got 8 external networks we've been invited to be a part of. We take 50 trainees a year. It's what we did in 6.5 years. Next slide. Couple of things about the team demographics. So there's 20 of us on the team, myself included. The gender breakdown is almost even. It skews toward women. The breakdown of racialized and non-racialized group identities is almost even. It skews slightly toward white identifying, but not very strongly. Next slide. 75% of the team identifies as living with a disability. Of that 75%, 60% identify as living with vision loss. Next slide. The data actually shows that the team skews very slightly toward people who were born in Canada. 9 of us were not born in Canada. 11 of us were. The last pie chart on the right of the slide is the intersecting marginalized identity pie. The blue segment is zero intersecting marginalized identity, which basically means you're a straight, white, able-bodied male. And then 1, 2, or 3 plus, orange, gray, and yellow indicate the numbers of intersecting marginalized identities that people on the team identify with. The obvious thing that you should note is that of the 20 people, there is not one single straight, white, able-bodied male. Next slide. Not that we wouldn't hire any, just that we don't have any. So when the team was founded in 2017, October, we had a core set of research objectives. There were 4 of them. The first was to collaborate with the research community in measuring and understanding the impact of sight loss on social determinants of health and social inclusion within the Canadian population. We set ourselves up at the very beginning as a primary data gathering entity. We were a knowledge, and we are a knowledge generation team. This is very different than many research entities that exist within nonprofit spaces. Some of them fund people, like people in this room, and some of them do market research, but most of them don't do knowledge generation. I'm going to go out on a limb. Feel free to cut it off behind me. But we happen to be the largest engine of knowledge generation in the nonprofit space in the country. Right? Our second objective is to develop a longitudinal understanding of the impact of programmatic intervention on social determinants of health within our client population. Full disclosure, we couldn't do that. The reason we couldn't do that was the organization's data systems weren't mature enough to actually make this question work for a variety of reasons. Up until 2018, CNIB's client records were all kept in Microsoft Excel, which is a fantastic place to keep that kind of data. So it wasn't well integrated. It wasn't well curatable. You couldn't do anything with it because there were about 200 Excel spreadsheets, none of which matched with any other. So that was the thing. So this objective, as much as I wanted to do it because it was part of my pitch to get the job, couldn't be done at that point in time because we did not have a mature equivalent of what in the healthcare space would be an electronic medical or electronic rehabilitation record. Next slide. Other objectives, we wanted to compile and curate a comprehensive series of metrics that document the impact of sight loss on social determinants of health in Canada. So there we wanted to focus on the curation, the translation, and the dissemination of knowledge, as opposed to just the generation of knowledge. And we wanted to educate relevant stakeholders about the key findings arising from our research endeavors. Next slide. Our approach to this again, this is the nonprofit sector, right? Research in the nonprofit sector doesn't get a whole lot of respect. And I started with a $0 budget. And my salary was in somebody's budget, but it wasn't in mine. So we did this by collaboration. I went into CNIB as head of research with a bit of a reputation. And I leaned on that reputation to help build the program. So there was word of mouth. I brought pre-existing relationships into the space. We have minimal resource needs. We can do everything that we need to do with SurveyMonkey and Zoom. Nothing fancy, right? Every piece of data that we could collect, we can collect with SurveyMonkey and Zoom. Those were relatively cheap platforms. We lean into student engagement. Ironically, not from an institute like this one, but from a whole bunch of other places. And we should talk about an institute like this one actually contributing students to the cause, because that'd be really nice. And so the student engagement is collaborative. A lot of it is practicum based, and it is fundamentally inclusive. Most of the students we get have never worked in an environment that is disability led, disability driven, and focused on doing disability focused, disability inclusive research, right? And so there's a little bit of mindset change that has to happen when we take our students, because the students honestly need a little bit of conditioning to be broken, right? And I have said to PhD students, and I have said to postdocs who have come into the space and not changed their more traditionalist research mentalities and research attitudes, you know, you're not allowed to disrespect the people on this team, right? You can't do that. If you do that, you're fired. I will tell you a story. I had a second-year undergrad student from the University of Toronto who wanted to be a phaco surgeon, cataract surgeon, come to me and want to volunteer as a research volunteer. And so he did. And his research question was aging, dementia, and vision loss. I gave him that as a literature review right before the pandemic. That's a fun question, right? I think it's a really important question. He spent 3 months not really getting very far because he was coming at the question from a fundamentally different mindset than I wanted him to come at the question from. And so we were having a conversation, and he was telling me about what he was doing, and he said, blah, 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 people suffering from vision loss. I said, excuse me? He said, people suffering from vision loss. I said, no, we don't say that, right? And it was a phone call back in the days when we had those things. And so I could tell he was staring at me blankly. You can hear the blank stare. You really can, right? Or my ears are attuned to it because I live with low vision. So I heard his blank stare. And I said, look, that's disrespectful terminology. It's disrespectful language. These are actual real human beings we're talking about. We don't refer to anybody like that. He said, I'm really sorry, Dr. Sukhai, it won't happen again. 1 month later, it happened again. I said, we had a conversation about this. I warned you one time. I'm going to warn you a second time. This time I will tell you, because you didn't listen the first time, that the next time you say it, I'm going to fire you. 30 seconds later, suffering with vision loss. I said, you're fired. He said, excuse me? I said, you are fired. Goodbye. So we don't take students with inappropriate terminology stuck in heads kind of thing. And so we work to change that mindset. Changing that mindset ultimately means that if you're a student with us and you go off and you do your own thing later, you will have hopefully learned something, and then you will take that with you into where you go next. And that's how we change the world, one student at a time. The projects that we do are focused on strategic planning, but we also are very opportunistic about things that get dropped in our laps sometimes. And so a little bit of that is every researcher following the money kind of thing, right? And so we do sometimes say, that maybe isn't our question, but it's a darn good question. Let's go ahead and ask it anyway. And we have a team that is built on inclusion. We evolve inclusion principles. I am CNIB's Chief Accessibility Officer alongside being its Vice President Research. And that's an unusual pairing. Most Chief Inclusion, Chief Accessibility Officer roles in the nonprofit space are stuck in people and culture, or they're stuck in marketing, or they're stuck in IT. My brother's in IT. I'm not. I'm not even remotely a good marketer. And I know enough about people and culture to tell you the million ways they do it wrong. Right? So I'm not in any of those three departments. And research would ordinarily be paired with marketing. And it isn't. Right? So we've taken an independent research entity and coupled it with an independent inclusion, diversity, equity, and accessibility team and turned that into a novel construct that doesn't exist anywhere else, that leans into the cycle between evidence generation and development of evidence-based idea principles. Next slide. That's what I just said. Next slide. Okay, so inclusion, diversity, equity, and accessibility, that's what IDEA is. I don't call it EDIA. I don't call it DEIA. I don't call it DIEA. None of that. It matters which letter goes first. And I tell you, I should have copyrighted in December of 2017 when I first used IDEA. It's become so popular, I could have made money on it. I didn't, so it's in the public domain. Please, everybody use it. Next slide. So pre-pandemic, we were very much the tortoise, not the hare. We were slow and steady wins the race kind of thing. So the department was incepted in October of 2017. The first research staff person not named Mahadeo was April of 2018. Our first major project went live the same month, the International Levels of Employment study that we did in collaboration with Australia and New Zealand. Our first MITAX funded student came to us in August of 2018. Our first collaborative multi-university partnership with Queen's and Dal came about in January of 2019. Our K-12 education outcome study was spring of 2019. Our guide dog advocacy study was spring of 2019. Our first Queen's Masters of Public Health Practicum student was summer of 2019. We first launched our very first iteration of a compendium of data on vision loss in Canada called Facts and Figures About Blindness in Canada in fall of 2019. We did a worldwide employment study with the World Blind Union in fall of 2019. Our post-secondary education outcomes study was winter of 2020. Our first ASC grant application went in the first round, also winter of 2020. And then everyone remembers March 13, 2020, because that's when the pandemic started. Next slide. So it's been a long road from there to here. We started, as I said, with no projects. The left set of bars is research project growth over time. As I said, 29 in 2023, a pretty decent incremental uptick. 2 projects in 2018, 8 in 2019, 7 in 2020, 10 in 2021, and then things exploded. So 20 and now 29, and that number keeps going up. The student numbers exploded as of the pandemic. So we had 1 trainee in 2018, we had 8 in 2019, we had 25 in 2020. I tell you, we weren't the only people who were doing this, but we were one of the first who publicly said, your trainees can do research virtually because of what we do and how we do it. If they can't go anywhere else and you need them to go somewhere, send them to me. So 25 students in 2020, and that number has kept going up 30, 40, 50, right? Our projections going forward are probably somewhere around 75 students at steady state a year. Next slide. So I put the same data up there and I color coded the bars. Orange is COVID and purple is what we call euphemistically the post-COVID era. And so what happened during COVID? Next slide. There were lots of barriers to doing research during COVID. No in-person data collection, no meetings in person, no funding for permanent staff. We had a hiring freeze. And we had the question of how to do everything virtually. But we also had opportunities. We had every single one of those barriers was an opportunity, right? Because we needed to figure out, could we do data collection virtually? And I said SurveyMonkey and Zoom. So the answer is yes, right? Could we do virtual meetings? I said we had Zoom. The answer is yes, right? No funding for permanent staff. So could I lean into students? The answer was yes, right? How could we do everything virtually? We figured out how to do that. And in fact, my team for the organization and for a lot of other people actually pioneered how to do a lot of these things virtually and accessibly. We were asking new research questions. We were asking the impact of COVID on everything and everyone. Our impact of COVID survey went into the field 3 weeks after the pandemic hit, right? And we were willing to virtual supervise when many other people were not. Next slide, Tilak, thank you. Over time, we've actually grown out a knowledge translation set to go along with all the knowledge generation that we do. I mentioned facts and figures about blindness in Canada. We do every 4 months student research days for all of our students. They will talk about their projects in a virtual symposium. And all of our collaborators are usually invited, and we make a big deal out of what the students have done and give them the chance to show that their work contributes and means something. We present at conferences, we publish where we can, technical reports and papers. And on an annual basis, starting last year, we run a co-design festival. Our next one is on March 11th at the Microsoft campus. I am looking for volunteers. So if anybody wants to volunteer for the co-design festival, come up to me and we'll talk. Next slide. So we build an inclusive research training environment, and we do this through role modeling. Our staff complement at one point was 100% persons with disabilities. Today, it's, as I said, 75%. I, as department head, have lived experience, and as Tilak pointed out, I'm of that generation of department head, a mid-career scientist who's acknowledged his lived experience long enough and so thoroughly that one can't actually Google me without figuring it out. Even academic search committees can't Google me without figuring it out, which posed interesting problems back in the day. So I'm very open about my lived experience with vision loss. I'm very open about my neurodivergence. So we lead by example. We model the kind of science, the kind of research, the kind of researchers that we need to be. We lean into mentorship and sponsorship. We co-supervise a lot. We do research supervision. We do a lot of career development and coaching as well. We focus on belonging and connectedness. We lean into virtual communities through our team meetings, especially for our students as well. We lean into a team social environment. We provide, because I've got staff in Vancouver on one side, and I've got staff in Montreal on the other. So I have staff across 4 time zones, right? And they're not all in the same place. We don't actually have a physical office, right? The highest concentration of staff members are in Vancouver and Kingston, right? And Kingston only happened in the last 2 weeks. But everyone's scattered throughout the country. So we have to lean into how to work virtually together. And we do inclusive supervision. So I let my staff talk. I encourage them to give the same freedom to the students. And we supervise the person, not just the project. Next slide. Our students come from all sorts of places. We get students from Sheridan College. We get students volunteers, Queen's Masters of Public Health, Queen's PhD Community Engagement Program, which will start in 2024 September. Next slide. Carleton University gives the students from their Masters of Health Sciences, Technology, and Policy, and from their BSc in Health Sciences. The University of Toronto at Mississauga gives the students, and we get capstone students from Ontario Tech University. And if you add up the numbers, we have on average somewhere between 30 and 39 students per term. Because a lot of those students actually overlap. They're the same students carried over from term to term. That's why I say our steady state's about 60 to 75, and it's 50 on a regular basis. Next slide. So that's what we are today. Let me tell you about the longitudinal study. And let me also figure out where I am in terms of timing. Okay, so next slide. So our study goals with the generational longitudinal study are to assess the long-term impacts of rehabilitation services and program participation on the well-being and the social inclusion of individuals who are blind, deafblind, and have low vision. The goal of the study is to use evidence-based findings to make informed recommendations that can shape public policy across various domains of inclusivity, and I'll take you through that. For the past 6 years, we've been running cross-sectional studies. Our employment studies are multi-time point cross-sectional. Our impact of COVID work was multi-time point cross-sectional. Everything else was single time point. Let's do it and let's figure out what's going on. But they're all cross-sectional studies, right? In order to really understand the impact of rehab service, the impact of program participation, you need to do longitudinal. You can't just do multi-time point cross-sectional. And so this is an evolution of what we've been doing using all of the resources at our command. Next slide. We have 3 specific objectives. 1, to develop our understanding of the holistic well-being, health outcomes and social outcomes of persons who are blind, deafblind, and low vision. To develop our understanding of the medium and long-term impacts of rehabilitation service outcomes and program participation outcomes on holistic well-being, health outcomes, and social outcomes of people who are blind, deafblind, and have low vision. And to make evidence-based recommendations, as I said. Next slide. There are 4 planned study arms to what we want to do. Study arm 1 focuses on children and youth. We are defining children and youth to be age 0 to 21. I could have made about 4 arbitrary choices as to the end cutoff of the age. I chose 21 because CNIB for 106 years has done 21. And so it's actually simpler just conceptually for everybody else for me to choose the same number, as opposed for me to choose, say, the UN definition, which is 40, or the Canadian government definition, which is 24, or somebody else's definition, which is 29. And so we'll follow kids age 0 to 6 more regularly than we're following, more frequently, sorry, than we're following kids 7 to 13 or 14 to 21. But we're also following parental perspectives, right? Because there's only so much that we're going to get from communicating with a 6-year-old. We'll get a lot more from communicating with their parents. But on the other hand, a 16-year-old would probably not want us to talk to their parents, would rather we talk to them, right? So over time with the children and youth arm, we'll evolve how those conversations happen. Next slide. So our questions: among children who are blind, deafblind, and have low vision, how are environmental, societal, and systemic factors associated with well-being, health outcomes, and social outcomes? And the emphasis here would be on the educational experience, the educational environment, social well-being in the context of school, things like that. Among children who are blind, deafblind, and have low vision, how do services and program participation affect those same things during critical child development stages and into adulthood? Next slide. 2, 3, and 4, we're interested in blind, low vision, and deafblind adults. So study arm number 2 would be the adult, like myself, who lives with congenital blindness or who acquired vision loss before a certain point in their life, and we arbitrarily picked the age of 55. And so these are adults who have lived with vision loss for a relatively lengthy period of time, right? We are taking adults into the study age 21 and up. And that means we're going to have a mix in this group of folks who have vision loss from a very young age and folks who have vision loss as an adult, who are going through adjustment to vision loss, and then who have sort of a different perspective on the world based on when they come into the study. Arm 3 would be adults with age-related vision loss. This is the group of people who, over the age of 55, have lost some part of their vision as they age, right? That's a very different set of experiences. It's a very different set of psychologies. As I said, you know, somebody who's 65 going for cataract surgery wants to be able to drive their car. I've never driven a car. Please don't ask me, by the way, if I miss driving. One can't miss something one never did. And then arm 4 is deafblind adults. And deafblind adults are called out specifically because deafblind, capital D, refers to those who have significant vision loss and significant hearing loss, to the point where the hearing loss can't compensate for the vision and the vision loss can't compensate for the hearing. And so this is a group of human beings that may or may not communicate through ASL, may or may not communicate through deafblind intervention, but certainly has as a group a different set of quality of life, lived experience, and it's worth it acknowledging that that's the case, and it's worth it pulling that aside and having a conversation about that population with that population separately. Next slide. Same research question as before with the kids, right? So what are the medium and long-term impacts of access to education, employment, technology, services on the well-being and social inclusion of adults 21 plus who have low vision, vision loss, and are deafblind? Next slide. What are the outcomes we're going to measure? There's a whole pile of them. So we're looking at educational outcomes, including educational experience, employment outcomes, including employment experience, assistive technology use, mobility and road safety, transportation use, access to healthcare, access to social services, well-being, physical activity, quality of life, access to information, future planning, independent activities of daily living, which is what IADL stands for, civic engagement, including volunteerism, advocacy, because people don't actually realize this, but there are barriers and cognitive load experiences associated with advocacy and self-advocacy, literacy, so reading literacy, financial literacy, technology literacy, housing and food safety, social connectedness, mental health, health outcomes. There's going to be some overlap across some of those domains, but that's what we're looking at. And we're also looking at a series of psychometric variables, which are character more than characteristics. Next slide. The next two slides, in fact, we can just go through very quickly. They outline in which arm of the study are which of these outcome measures likely to be collected. And for the most part, they're going to be collected everywhere. Next slide. And next slide again. The children and youth arm, of course, some sections of what we're going to do are applicable only as the kid ages. We're not going to ask a 6-year-old about their employment history, right? And so for some things, it actually matters how old the kid is and how we're going to proceed through the interview protocols with them. And as I said, we're interviewing parents until children are 10. We're going to interview parents and kids together until children are 16 or 17. And then we're interviewing youth alone until they graduate from the study. We care actually very much about interviewing the parents to understand the parental perceptions and the parental attitudes and biases towards sight loss. And I'll explain why later. Next slide. Psychographics. There's a list of things that we're interested in. We started with a list of 60 psychographic measures. We whittled it down. We're really interested in things like self-efficacy, resiliency, emotion-based decision-making. We're interested in things like impulsiveness, locus of control, self-esteem, domains of creativity. Next slide. So we have a model behind this, and our hypothesis is your demographic characteristics are your demographic characteristics. Some of those can change, right? And they will potentially flux over time. But then that coupled with your program and service participation, so number of programs you're interacting with, length of interaction, how long you're spending with programs, the quality of your interaction, those things are going to influence character, not characteristic. They'll influence your psychographics, your psychometric variables. Those psychometrics themselves will influence social inclusion in the long term. And so the model that we would work with, that we are actually trying to test, is the model that says that participation in programs and services drives your own change in terms of resiliency, in terms of locus of control, and so on. And those changes will drive your long-term social inclusion outcomes. Next slide. Multiple intersecting data sets. Participant demographics. Program participation data set, which we're getting out of Salesforce, which CNIB uses as its customer relationship management system. Vision loss rehabilitation service provision data set, which we're getting out of Salesforce Health Cloud, which is what VLR uses. And the longitudinal study data set, we're investigating Qualtrics as our data collection platform. But we'll integrate all of those 4 pieces together in a custom integrated research data set that will be housed as an SQL database within CNIB's firewalls for the purposes of data mining and analysis. Next slide. So the demographics, the psychometrics, and the outcome measures are going to be evaluated against program participation data for individual study participants and rehabilitation service participation data for individual study participants. The key principle here is that it is quite likely that we can recruit somebody through an ophthalmologist's office who had nothing to do with CNIB before and who could care to have nothing to do with CNIB. But then over time, they decide they actually want vision loss rehab, or they decide they want CNIB programs and services. Your participation in the longitudinal study doesn't exclude you from participating in those programs and services if you didn't start out there. What it means we have to do is we have to also monitor underneath everything that we're doing, how people are fluxing in and out of CNIB and VLR programs and services over time. Because then we can map times of interaction onto all the data that we're measuring. Next slide. It's a 45-year study. That is not a typographical error. I will be 90 when this is done. Hopefully, I will still be engaged now. This encompasses 25 data collection cycles for children and youth, 8 data collection cycles for adults with sight loss, and 15 data collection cycles for adults with age-related vision loss. That last arm, the age-related vision loss arm, because of the complexity and how the numbers roll over year, we're not doing that until we get external funding and we get partners who want to come to the table. And Alzheimer's Canada, right? Dementia organizations involved in aging, organizations involved in caregiving, because nobody asks these questions. Nobody's asked these questions before. We're asking them for the first time. And a lot of people have actually told me, I don't quite know what you've drank or smoked. Can you share it? My response is, I haven't drank anything. I'm a teetotaler and I don't smoke. So I don't know what you're talking about. This is a legitimate scientific study. And I'm bold enough to say that, and also brave enough to stand here and take the criticism afterward. So we're not doing the age-related vision loss arm until we recruit collaborators, until we recruit funding, because it is logistically complicated, monetarily much more expensive than the other 2 arms combined. Next slide. We're talking to children and youth on average every year, adults every 5, adults with age-related vision loss every 2. Next slide. We were recruiting participants, or we will start to recruit participants using CNIB's internal mechanisms, program leads and client navigators within CNIB and VLR, optometrist and ophthalmologist offices, and then also through open calls and community-wide dissemination. We are targeting 200 kids a year, 400 adults a year, 400 adults with age-related vision loss a year. Our minimum goals are 1,000 kids, 2,000 adults, 2,000 adults with age-related vision loss. I would, of course, love more, but more also means we've got to find the research participation dollars to pay for them and the staff to support all of that. So more means more money. To start with, those are the goals. We've got 45 years to A, achieve them, and B, build on them. Next. Okay, so where are we going? Perfect timing, thank you. I'm done in 5 minutes. Actually, 10 minutes. So where are we going? This is where I want to, as the title of the Tillich sent out said, introduce to you the Blindness and Low Vision Research Institute. Next slide. So what's on this slide is what we think is a pretty simple model, but artfully, it's also a pretty complicated model. So the basic premise is this, right? As scientists, we love reductionist thinking. It's what we do by definition, right? So the challenge with reductionist thinking is you can't control for all of the variables that you need to necessarily control for. I was in a room 2 days ago in Montreal giving a talk at a Vision Sciences Symposium on the impact of attitudinal biases on the lived experience of persons who are white cane users and guide dog users. And I had to argue with the room, which was full of rehab specialists, because their perspective was attitudes don't matter and it's all intrinsic to the person. And my perspective, I was standing up there telling them they were all wrong. So of course that was it was a fun talk. It went well, but it was really interesting because I went into a hostile environment. And I told them I didn't think that they were right. So the premise behind this is that we don't live in isolation, right? And so there are things that are intrinsic to us, but we live in a world that is rife with systems and policies and processes, all of which are biased, right? And therefore those biases and those systems, those policies, those processes influence how we interact with that world, right? It doesn't matter, and I'm going to use a specific example here. It doesn't matter how well an employment services person prepares you for a job interview as a person with a disability if you have an ableist hiring manager at the table, right? It doesn't matter if you, as a person who uses a white cane, and I sometimes do, mine is on the chair over there, right? If you as a person with a white cane goes into a job interview with that white cane, prepared to defend your ability to do the job, and all you get is questions about, well, how'd you get here? And how can you get around in the job, right? Because if you get those questions, you're never going to be hired. So the principle behind what we're doing is that the person-centered data matters, but also the systems matter, and the intersection between the two is what really defines in the outcomes of inclusion in society. Next slide. Our vision for what CNIB research is today and what the Blindness and Low Vision Research Institute will become is an international center of excellence for person-centered and systems-focused accessibility research, an engine for capacity building in the accessibility research community, and a world-class leader in knowledge sharing about the quality of life and lived experience of persons who are blind, deafblind, and low vision around the world. Next slide. We have 6 specific objectives: to collaborate with the global research community in understanding the intersection between blindness and social determinants of health through an intersection accessibility lens, to develop a longitudinal understanding of the impact of rehab and programmatic interventions on social determinants of health, to carry out systems level research to understand and propose solutions to prevent and or remove barriers to participation in society. We do a lot of that right now anyway. To build system capacity in the research community for the inclusion of researchers with disabilities and the performance of research according to accessible and inclusive best practices or standards. Red cap, excuse me. Allison's smiling, she knows what I mean. She's the only one who's going to get that particular joke. To compile and curate a global encyclopedia or a global compendium of blindness, and to educate relevant stakeholders about the key findings arising from our research endeavors. Next slide. The organization that we're creating is what's going to be called a wholly owned subsidiary of CNIB. That means that it's a nonprofit. It will be a charitable foundation. As a nonprofit, it has a single member, and that member is CNIB. That means that the operating head of the Blindness and Low Vision Research Institute reports the president and CEO of the parent company. That would be CNIB. And that person would be the Blindness and Low Vision Research Institute's chief scientific officer. There are 4 clusters of people on the team underneath the current CSO. That would be person-centered research, which itself is the longitudinal study and population data sciences work. And population data sciences really focuses on what we can mine from StatsCan data. Systems research work, which focuses on barriers and biases. Training and education, which focuses on student training and also the work we do in the international space to build capacity for international facing research questions, and thought leadership. Next slide. The governance of this entity would be by a small board of directors. It will have a scientific advisory board, a community engagement board, and we'll build our own research ethics board. Next slide. So why go through all of this work? You're launching a longitudinal study, Mahadeo. You're launching that study in the next 6 months. You're building a research institute. Why do that? That seems like a lot. And you have a 18-month-old, don't you want to sleep and, actually have a life? CNIB research today, none of us are eligible for SSHRC, NSERC, and CIHR funding. We're not because our primary appointments aren't post-secondary institutions, right? The parent organization, that being CNIB, doesn't have the ability right now to be eligible to administer any of those grants. To run the longitudinal study, we need access to those grants. We're not eligible for international research funding opportunities. We have a massive potential conflict of interest that exists because CNIB research exists in the same organization that does all the advocacy and does all the program and service delivery. A lot of our participants say, you don't care what I say because you already have the answer in mind. You have no idea how scientifically offended I am by that every time I hear it, but I hear it a lot, right? And at this point, we have ad hoc access to technical advisory expertise as opposed to something more systematized. What we hope to achieve with the Blindness and Low Vision Research Institute is an entity that has a health research and knowledge translation mandate that is eligible for at least CIHR. SSHRC and NSERC are a little bit more intransigent. I won't call them anything other than that. But they have specific requirements that if you're not in the academy, you can't apply, and I think that's rude and insulting. Through formalized partnerships, we become eligible for international research funding opportunities. Research will be separate from program services and advocacy. And we'll have a board of directors and a scientific advisory board and a community engagement board that can then provide the advice that we actually need. Next slide. We're building out operational streams, the longitudinal study, obviously. The systems level research, which really includes a lot of what we do right now. We've done research on accessible and inclusive employment. We've done research on accessible procurement. We've done research on guide dog barriers and access barriers faced by persons who are guide dog handlers. We're doing work on responsible conduct of research and best practices for accessibility and inclusion in responsible conduct of research. We're doing work on travel. We're doing work on accessible and explainable artificial intelligence. So all of those are systems barriers, and so that second bullet point is the one that we built out the most strongly. We want to lean into the national and international research networks that we have, and that we will soon become a part of, hopefully. We want to lean into research services, meaning that we can actually provide services to the community, not just to ourselves. And we want to lean into collaborative engagement and capacity building and lean into the global encyclopedia, as I said. Next slide. Our immediate impact opportunities in terms of capacity building, student engagement obviously is a big one. Training in accessible and inclusive research practices, and identification and cultivation of a network of researchers with lived experience. Not in my bio, I co-founded and now chair the International Network of Researchers with Visual Impairments and their allies. And so there's an ability there to start something and to develop something and to spin something synergistically out of what's already going on. We want to grow our credibility within the research community through an international network of collaborators. So research cluster memberships and or cultivation, collaborator-led projects, and collaborations on existing initiatives and new projects. What I try to make sure people understand is, yes, I might have a $2 million a year operating budget, but I'm not made of money. Because that $2 million actually is earmarked. All of it is earmarked. And so I don't really have, unless I bring in extra funds, the ability to pay for somebody to do something. So I very occasionally I have to say to collaborators, I am not made of money. And I will have to say to people who come to me looking for grants, I don't have grants for you, right? Next slide. Other opportunities for immediate impact is version 1 of that Canadian encyclopedia on blindness, deafblindness, and low vision. And our presence and visibility, conference presentations, talks like this, publications, that tells the world that we exist. Next slide. In terms of the knowledge translation that we can lean into in the first year and a half, the Co-Design Festival, as I mentioned, we do every year. CNIB runs a program for guide dog handlers called AdvoCamp. We do a research day there every year that is quite popular. Our student research days, if we open them up to more than just the collaborators, and then the opportunity to actually build out our own research conference or research symposia. Next slide. The networks that we take with us into this space include the Inclusive Design for Employment Access Network that is based at McMaster and the Institute for Work and Health, the Canadian Disability Participation Project 2.0 based at Queen's, U of T, and UBC, the Digital Life Institute based at Ontario Tech University, and the Spore Evidence Alliance. Next slide. So next, this beast's got to be incorporated. We've got to expand our infrastructure. We've got to establish our governance and develop our strategy. We've got to launch the longitudinal study and start to build out our sustainable funding model. And that's the next year's worth of work for us. Next slide. Questions?
Right here, to start by saying, wow, that's incredible progress over the last 3 or 4 years. It's amazing to see that, and to see your very ambitious plans going forward with this project. Any questions? Yeah.
Thank you so much, Mahadeo. This is wonderful to see your vision for this forward. As you're speaking, you said something about, you said COVID hit and then 3 weeks later, you launched a survey. Oh my God, 6 months and we're still trying to get our review for our survey. So I'm very curious, and later, at the end of your presentation, you said you're establishing your own research ethics board. So until now, how have you dealt with research ethics? When you launch these surveys?
So we deal with research ethics slowly and painfully,
Same as all of us.
right? Same as everybody else. The interesting, so one of the research studies that we actually have on the go, that responsible conduct of research study, we actually did a review of about 30 different research ethics boards for how much the research ethics board in their application and their platform pays attention to accessibility of persons with disabilities. Not Allison, because Allison knows the answer to this question, given some of the work that we've done together. How many out of that 30 do you think actually pay attention? Yeah, 0. Thank you, Patty. 0. Nobody does, right? It's horrendous. There's a poster at ARVO about it. The ARVO is the Association for Research in Vision and Ophthalmology, and so I actually have a poster that's going to have a big fat 0 on it. Figure 1, 0, right? It didn't get a talk because I don't think people felt that there was enough data. So it's a great question. So CNIB currently has an internal research ethics mechanism, right? And we rigorously follow that research ethics mechanism for ourselves. So that's actually how we got the COVID impact survey done in 3 weeks. Right? I didn't get Queens's approval or U of T's approval. We had our own internal approvals that we went through to do the study. The thing is, we get a lot of requests for research participants. Yeah, Allison, yes, right? And if you happen to be a collaborator of CNIB research, hi Allison, right? Then it's easy to make that work because we can help you go through the process. If on the other hand, you're not a collaborator of CNIB research and it's a random request that comes in and we get, oh my goodness, so many of these, then usually I'm in a position where I have to say, okay, you're actually not compliant and here are the many reasons you're not compliant. So it's almost easier to actually go through the process of having a formalized research ethics structure, particularly since research will become an independent entity. And so the who is responsible for dealing with a research request from, Waterloo University about self-service kiosks, right? Because I don't own client lists, right? And the client lists that I will own for the generational longitudinal study are not a client list I'm going to give to anybody else because I can't do that. That's not ethical. Right. So because you have an independent research institute within a space and different people own client lists. So you actually have to create a more formalized structure than we had before when everybody was under one roof.
Totally different question, but you
The question I had about this longitudinal study was just, has anyone done like this? I'm not familiar with these longitudinal studies. It seems extremely ambitious. What have people done in the past?
Yeah. So what's been done in the past? A couple of things. One, you have a very small study, very qualitative, and you're focusing on, less than 100 people and you're having a conversation with them for a long period of time. 2, you have a relatively small study. It could be more people, much shorter period of time. And you're concentrating on something really specific, right? So for example, somebody could do a year-long longitudinal study on educational outcomes of kids with vision loss and have 200 kids in the study, right? But it's a year long, September to June, right? And so your time for intervention and management, it's not great. The other way that people have done studies like this, if they've been bigger, is they've sort of said, well, I have a very specific question. My specific question has to do, for example, with access to healthcare. right? Or my specific question has to do with access to assistive technology. So I'm going to focus in on that one thing, and I'm going to collect data over a 5-year period or a 10-year period, right? What we're attempting to do most closely resembles the Canadian longitudinal study on aging, except without all the medical data, right? Or in the UK, they had something called a Millennium Study, where they took every kid born between 2000 and 2002 and enrolled them in this study over a 20-year period. And they had something like 10,000 kids participate, but of the 10,000, only 200 had vision loss. So there's only so much you can actually mine from things like that. So what makes this unique and potentially also scary, and also why a few people have said to me, really, what are you drinking and smoking? Is we've decided that the economy of scale in collecting all the data versus collecting only a piece of the data isn't actually worth it. It's not worth it to just collect a piece of the data and then do another study years down the road to collect another piece of the data when you've got to ask the same baseline questions around demographic and psychographic anyway, right? So if you're collecting all the participant characteristics, if you're collecting all the psychometric information, then why not collect education along with employment? Why not collect assistive technology use along with access to information for daily living? Like, why not do it like that, right? And so from that sense, whereas StatsCan, when it does things like the Canadian Community Health Survey or the Canadian Survey on Disability or even the census, it's collecting information in long time scales in a multi-time point cross-sectional way. We want to be ambitious enough to collect that volume of information about a very specific population in a longitudinal way.
Yeah.
And then I guess there's one question. With this CLSA, there's a mechanism for researchers to ask questions and to break out your data set.
Yeah.
And so will you have that mechanism in place?
Yeah. So the actual question set's about 600 questions long. That is not going to be delivered in a single survey. We've chopped it into 18 modules, I think it is, based on what I showed you on the slide. Each of those modules, so 18 modules over 12 months, right? So then you're delivering a module once every 3-ish weeks. Right. And so then you've got something that's bite-sized, that's like, 600 divided by 18, so 30 some odd questions per, right? 30 some odd is much more manageable than 600. You can do a 30 some odd question survey in 10 minutes as opposed to a 600 question survey, which we've timed to take 6 hours. And so that way, what you're actually also doing is drawing out interest, engaging with the participants over a longer period of time. And for kids, that'll just roll over. You're done 18 modules in 1 year, you go straight back to the beginning again. For adults, there's an interregnum, there's a pause, and then you come back again, right? We're also not recruiting everybody all at once to do this. We're doing rolling recruitment over a 5-year period. And so in the case of arm 2, the adults with vision loss arm, we're talking to only 1/5 of the cohort each year. So that gives us an opportunity to really concentrate on what they're telling us.
Then I need clarification. So I have an interest in that little component where you talk about transportation.
Yeah.
For whatever reason. I have a sub-research question.
Yeah.
Do you know,
So we're
do you
collecting.
guys plan on analyzing everything in-house, or do you plan on farming it out to us?
So that's the fun question. We plan on building research collaborations around that.
Yes, okay.
And so-
That's what I wanted
so-
to hear, okay.
So yeah, I mean, we can do the analysis in-house, but it also becomes much more helpful to the cause if somebody comes and says, you've got this data set, I want to write a grant about it. And yes, I recognize that I've got to carve out administration costs for you and staff costs for you to administer all of this. But can we actually do that data analysis for you this time through or the next time through or whatever? Exactly.
Nice.
I have to remember that because my board doesn't quite understand right now. The CNIB board doesn't quite understand how a study like this works. And so they wanted to see a 50-year plan on how it was going to be funded. And I have to remember that answer.
Stuart, we'll come to you in just a second. There's a question for online. Barakaslaw is asking, how does the proposed organizational structure allow for engagement with those of us developing assistive technologies like smart glasses? What are potential pathways to collaboration? Will the Research Institute itself be involved in the technology design and development?
If we've got the right research question around it, yes. My advice to you is always have a conversation with me and with us, and we'll figure out ways to partner. We'll figure out ways to do something. If somebody comes to me and says, can you do market research on the use of these smart glasses that we've already made, my answer is going to be no, we don't do market research. But if you come to me and you say, you know, we've got this thing, we actually want to put it through an appropriate set of human-centered trials and human-centered development, then I would say, yeah, let's have a conversation about it, because that's a critical piece of work that often gets missed in the development of assistive technologies. I hope that answers your question.
Yeah, I think that's, we can see it from us.
You're welcome. And my email address was on the title slide, so feel free to reach out. Stuart.
Mahadeo, this is awesome. I love what you're doing. It's really exciting. Huge potential. So what I'm interested in most these days is both relationships and communication. So the questions I have are, as you're starting this process and building this, what relationships are you building with government and with people at the other end as you get these really amazing results to actually bring this into a much more wide-spanning impact on society and on changing the policy, changing the way that people are seen, the way things are handled, and actually bringing this to the point of actually changing the hearts and minds of, you know, when people are perceiving people a certain way. That's one.
Hold on, no, wait, because I know you like asking multiple long-winded questions. Let me answer this one first.
But okay.
Let me answer this one first,
Fine.
because I will forget it by the time you're done.
Okay.
Okay. And so my answer to that is the community that engages in the data collection will be a community, much like with the CLSA, that community gets passed back research findings as they evolve and gets engaged through conversation and dialogue, right? What we would want to do in a space like this is over communicate. Particularly in the beginning, to talk about the potential of the study and the value of the study and why it's important to participate and why the data are not just going to go into a black hole, right? And so over communicating that brings people in, but then once you bring people in, you have to continue to engage with them and maintain that relationship and make sure that you don't lose them, particularly the adults who have that 4-year gap between the end of module 18 and the start of module 1 in the next cycle, right? You have to make sure that they're constantly made aware that stuff's always ongoing and you're learning new things all the time, right? And you can do things like a refer a friend program and all sorts of things to keep people engaged in the study. With respect to the point about, well, here's what the findings are and here's what it means and here's how people intend to use it. We're the Blindness and Low Vision Research Institute. CNIB owns the advocacy piece, right? CNIB will forever own the advocacy piece. The advocacy that I engage in is the research advocacy. It's the one where I go to CIHR and say, you know, you need to do this because if you don't do this, it's kind of silly. Or the one where I write scathing letters to REB chairs to say, your survey platforms are not accessible, don't use them, right? So research advocacy is an important part of the job for the Research Institute, but it's not the same as the data suggest that this suite of assistive technologies need to be funded by the Assistive Devices Program. So what ends up happening is on the back end, I say to you know, our friends in CNIB Voice, which is what the advocacy team is now called, this is a key finding. You take this, you run with it, you mobilize the community, let us know how we can help, right? So our job is to tell the world, and our job is to point the way to the implication and then help, but not drive the advocacy conversation.
Okay. But is it possible to establish direct relationships with ministers of provincial, municipal, and federal government to actually, like, Minister of Health, the people who can actually watch this happens, as, people making decisions ultimately for funding and for, supporting certain treatments, supporting certain interventions, supporting, funding for mental health and wellness, for example, or supporting, what is funded by OHIP, other things like that, to actually, based on your findings,
So the short answer is yes. The long answer is I may not own those relationships. They might be owned by somebody else within the family, but
Okay.
it is entirely
Great.
possible to do all of that.
Okay. And I'll make the second question really quick, but the other thing, again, sort of communications and relationships, but you said you're going to have a community engagement panel or a group, committee as part of the organization. So what do you see the role to be that they will play through the whole process? Like, is it, at the beginning, through the entire process, the research, beyond, like, will they actually have the opportunity to, one way or another, participate in the research? I mean, whether or not they're initially participants, but will they be brought in as an advisory council the entire process, or what,
Well,
is there a lot of people taking this on
yeah,
at some level?
so a community engagement board would have to be a community engagement board for the organization and all of the organization's work, right?
Okay.
So yes, they can participate. I will tell you that where we have a little bit of a challenge with community engagement right now is the community members have a hard time wrestling with where research ends and where advocacy begins, right?
Mm.
And so I'll give you an example on the project we did with guide dog handlers on guide dog access barriers. The advisory committee went very quickly from, okay, this is what the research findings are, to, can you advocate to Uber about Uber drivers being stupid, right? And the answer is no, actually, we can't, because that's outside of our remit as an entity. Our incorporation papers will not include advocacy as part of the incorporation documentation, so we can't go there.
Yeah.
It won't be part of our objects, but other people can go there and we can facilitate them.
Okay.
Right?
Good. Yeah.
Where I currently run into issues is when somebody will come to me, for example, and say, there's data that's collected on, for example, the accessibility of self-service kiosks, and somebody is suing somebody else because the self-service kiosk in the retail store is not accessible. And so some lawyer comes and says, I need your research to have said the following thing because the following thing is embedded inside my legal argument. At which point I say, I'm sorry, I can't do that if my research or the research of the team doesn't demonstrate that. I have ethics around lying to people. And so but I've also been in scenarios where the lawyer will say, yeah, but I need you to say this and I need you to sign this deposition, and that like I don't want the team to have to deal with stuff like that, right? And so that's one of the reasons that we need this kind of separation.
It's okay if I ask one last quick question. I promise I'll pass it on after this, but do you see yourself ever being able to distance yourself at some level from CNIB and affiliate yourself with actually university, like with the University of Toronto or York or other things, and actually become
Why would I do that?
Sorry?
Why would I do that?
To become a group that could then be considered for grants and other funding sources like other, and I don't know the.
Why would I do that if I'm doing this?
Okay, expand on that.
So there's other ways for me to actually do this.
Okay.
The other way to do this, which my boss would fire me over, by the way. So thank you for suggesting it, because it suggests to me that you want my job,
Okay.
right?
Fair enough.
So the other way of doing this is to sell CNIB research.
Yeah.
To a Queen's or to a University of Toronto.
Fair.
Here's the problem. The current climate of academic research is not accessible nor inclusive to persons with disabilities.
That's fair. Yeah.
And I have a team that's spread out across the entire country. And so if a Queen's were to actually swoop in and pay CNIB X number of millions of dollars to take over my team,
yeah,
and assume all of the assets associated with it, everybody on my team, save 3 people, are out of a job.
Yeah.
Right?
I get it.
I'm not going to do that to them.
I get it.
Right? That's one problem. And the second problem is, like I just said, the academic research enterprise is currently neither accessible nor inclusive to persons with lived experience with disabilities. I would have no guarantee that even an institution as august as the University of Toronto, where I did all of my training, actually knows what the hell to do.
Sure. I know what you mean. Fair.
Great question.
Thank you. Thank you. Yeah, probably. Thanks.
Great. Any other questions? No? Okay, maybe we'll wrap it up here and we can come chat with Mahadeo after. Let's give him one more round of applause.